the first one is a perfect illustration of what we talk managing of the geometry of the knee, and already highlighted by Dr. Said Altani. And this one will be one more illustration. It's a case of a 30 years old professional football player. He had the right ACL reconstruction using upswing 6 years before, and he had no postoperative problem. He returned to play 7 months after surgery. At 1 year, he had the same level, and he played at high level 4 years without any complaint. And 6 months before I saw this patient, he had a right knee injury during a reception only. No, he didn't mention any twist, and he felt a pop, no real pain, and swelling the next day, rest, self-exercise, and he came to me with this complaint 6 months after this injury, instability during sport and sometimes even during the daily activity, despite good physiotherapy. The physical examination showed a normal alignment, full range of motion, Lachman grade 2 endpoint, and with a Lachman 11 millimeter difference, and a pivot shift grade 2. No pain, no swelling when I examine this patient. So this is the first assessment, imaging. You can see that the joint line are okay. We can discuss maybe the lateral femoral tibial joint line, but if you compare with the opposite side, it's almost the same. The tunnels, the look on good position. They are not really dramatically enlarged. It's under button on the femur and the staple on the tibia. The MRI, which was done immediately, of course, as usual, confirmed the deficiency of the ACL graft. If we cannot talk about tear, at least degradation of the ACL graft. Slight medial meniscus tear. Lateral meniscus intact. I think he had the lateral meniscus repair during the first surgery that I didn't do. So the question is, what is missing in this imaging? You know now, it's the assessment of the geometry, which is absolutely crucial. First of all, with the long leg varus valgus measurement, he has a slight varus or no varus as usual in this region, as said Dr. Said. But when you look at the long tibia lateral view, you can see that the tibial slope is increased, definitely more than 15 degrees. And we know that in theory, at least, but you know, it's not only in theory, the increased posterior tibial slope leads to a tendency for the femur to slide backward relative to the tibia, then increasing the load of the ACL. And already in the past, Henri Dejour in France demonstrated that increased anterior tibial translation on monopodal stance views was correlated with increased posterior tibial slope in patients with an intact ACL, as well as those with chronic anterior laxity. So it has an effect on normal ACL or, of course, on deficient ACL. The posterior tibial slope is described as excessive when it is greater than 12-13 degrees. And some authors, particularly the French Lyon School, recommend the addition of a tibial deflection osteotomy to a revision ACL reconstruction when the patient has a posterior tibial slope greater than 13 degrees, when, not only when it's greater than 30 degrees, but when it's associated with increased anterior tibial translation, at least 10 millimeter on the radiograph or on the GNRB or KT 1000 or 2000 when you have the opportunity to use this kind of thing. So what was the plan for this patient? ACL using BTB because the hamstring was already used, meniscus management and treatment, tibial slope correction because for this revision we don't want to have a risk for the new graft if we don't correct the tibial slope, excessive tibial slope. The question is about the lateral tenodesis. We can discuss. In this case, I didn't do lateral tenodesis. It was in the past, and I think now I would do combined lateral tenodesis, but this is something that we can discuss. So the treatment is this one. I do first all the procedure of ACL revision with the BTB graft, and the deflection osteotomy is done later on, okay? So the osteotomy is performed with the knee 90 degrees of flexion to minimize the risk of neurovascular structure. The anterior closing wedge osteotomy is performed just proximal to the attachment site of the patellar tendon. There is different technique, but this technique allows a good compression and good stability of the osteotomy. This is a technique I learned with Philippe Landreau from Lyon School that you know. So in this case, of course, I didn't do a minimal invasive technique because I had to do the tibial osteotomy. So I did the extensive anterior approach to harvest my BTB. You use for this technique guide pins. And in general rule, you must remember that 1 millimeter of closing result in a slope change of approximately 2 degrees. So you measure what you want to remove on the anterior part. And it's important to put the pin reaching the posterior tibial cortex just proximal to the tibial insertion of the posterior capsule of the D joint. So it ensures the integrity of the posterior hinge during the closure of the osteotomy with the PCL, which stabilizes the posterior part of the osteotomy. So you see this fluoroscopy image. You reach the posterior cortex, you progressively remove the anterior cortex, you perforate the posterior cortex with the 3.5 millimeter drill. Pay attention to not go too far. You understand why? And then you gently extend the knee and you close the osteotomy in that way. Exactly the same procedure when we do a closed valgus tibial osteotomy with the technique of closed lateral osteotomy. So here it's anterior. If you want to correct a little bit the varus of the valgus, you can remove more cortex on medial or lateral, usually lateral because it's a varus. Otherwise, pay attention to not create varus or a valgus, usually varus. And then the fixation is very simple, no plate, 2 large staple, traditional, and it works very well, one on either side of the patellar tendon. This is a post-operative image of this deflection osteotomy, and this is the result of 3 months. The post-operative management is almost the same, partial weight bearing during the 3 first weeks, so then progressively weight bearing because it's a compression on the joint, on the osteotomy area. So no need to put in no weight bearing during 6 weeks. We can mobilize the knee as it comes without any real restriction. So in other words, a little bit like a normal ACL revision, but with a progressive return to weight bearing. So is there evidence that the geometry impact the knee laxity? Yes, there is. There is clinical evidence supporting osseous malalignment as a factor contributing to failure of knee ligament injury, either varus, which is frequent, or tibial slope. And in the same time, there is clinical evidence that when you realign the knee, you can improve the function and the stability, especially in case of combination with revision ACL surgery. So there are some papers. There's no strong evidence because there are no real comparative study, but it's clear that all the papers in the literature now show that the revision ACL reconstruction combined with HTO improve the result and the outcome. The rate of complication is not so much, surprisingly. There is no evidence still now about the effect on osteoarthritis, but in terms of result of stability, knee stability, and the outcome, there is clearly an improvement. So the take-home message, because when we do a revision, either a revision from another colleague or your own revision, we always need to learn something. What we can learn with this kind of thing is any evaluation of ACL graft deficiency or knee deficiency, but ACL graft deficiency must absolutely integrate a complete assessment of the knee geometry, particularly the posterior tibial slope in this case, because if you miss this deformation assessment, clearly you can increase the risk of ACL revision failure. Thank you.